Shall I start, sir?
Yes, you can start.
So I would be discussing ventilation-induced lung injury mechanisms and how to prevent it. Then next I would be moving towards weaning and extubation, role of extubation readiness test, pharmacological support, respiratory support, and nursing care to be provided during peri-extubation period, and when should be labeled extubation failure. So as we all know, mechanical ventilation is one of the most common procedure in the neonatal intensive care unit, with incidence as high as 60 to 80% in extremely low birth weight babies. And if not used judiciously, it can lead to various uh, complications of mechanical ventilations like ventilation-induced lung injury, airway trauma, infections, increased duration of hospital stay, ultimately leading to bronchopulmonary dysplasia, increased financial burden over family, and neurodevelopmental impairment, as well as death. So, the first part of my talk is ventilation induced lung injury, and there are various types of this ventilation induced lung injury. It could be volutrauma, atelectotrauma, barotrauma, biotrauma, oxytrauma, and rheotrauma. So the main components actually accounting for this ventilation-induced lung injury are volutrauma, atelectotrauma, and this oxytrauma. So why they are main, I would be discussing in my next few slides. So volutrauma is due to over tension and excessive stretching. There happens interstitial and alveolar edema. And the most commonly, we can see hyperinflated lungs in a neonatal chest X-ray in the initial phases. And when it comes to atelectotrauma, the inadequate PEEP usually leads to unstable alveoli, which results in repeated alveolar collapse and expansion. And X-ray picture can be similar to a patient like a patient with RDS. So one can very well understand why this high volume lead to volutrauma, but why? What about atelectasis? Why it causes the ventilation-induced lung injury? So there are very important concepts that the attendees used to, understand that. First thing is the pressure needed to open up a saccule or alveolus is always high than a pressure need to keep it open. Second, it has been observed that the stretching forces that happen at of this alveolar collapse and expansion is usually 5 times more than that happens at the open airway. So this high pressure usually causes lung injury. Third is
कि पटना ले जाए. हाँ 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 बोलेगा पटना हाँ बोलेगा पटना ले जाए. IGMS किसको? बिंदे. ओहो हाँ. ओहो. ठीक है तो इसको IGMS बोले ना, हम बिंदे बिंदे कुमार हैं. अब तो उन्हीं के पास ले जाइए, ठीक है ना? ओके ठीक है, भिजवा दीजिए इसको. नहीं किए थे, कल सुबह करेंगे. ओके.
So I was discussing about atelectotrauma. So the main point here was repeated alveolar collapse and expansion can cause injury. One was the pressure needed to open up a saccule or alveolus is always more than a pressure needed to keep it open. Second, it has been observed that the stretching forces that are happening at the junction of collapsed and open alveoli are 5 times higher than at the open airway. So ultimately releasing this high pressure leading to airway injury. And then there is a regional volutrauma. What happens when there is a atelectasis in certain regions? So the delivered tidal volume takes path of least resistance, and rather than inflating collapsed alveoli, it gets transferred to the airways, which are already open due to their low critical pressure and resulting in the volutrauma of already opened alveoli, leading to heterogeneous distribution of the lung volume. So what is the main pathogenesis behind this volume trauma and atelectotrauma? So if we see here, we have a normal alveolus where there is and there is a capillary alveolar capillary membrane and interstitium. So this alveolus have there is a air space. There are type 1 and type 2 pneumocytes, and then there is a alveolar macrophages and the intact endothelial cell layer, basement membrane, and epithelial basement membrane. But when volutrauma or atelectasis happen, it leads to the denuded basement membrane and ultimately leading to alveolar flooding, which usually happens to the necrotic type 1 cells. There would be damage to type 2 cells, which leads to inactivated surfactant and ultimately would be causing neutrophil influx, which causes the capillary leak, and the fluid in the interstitium would be more, and this will ultimately lead to volutrauma and atelective trauma. So next is barotrauma. So it has been observed that high inflation pressure would cause air leak due to disruption of airspace wall. So it can be shown as a case of pneumothorax in a neonatal X-ray, or can present as a pulmonary interstitial emphysema. But the important point to note here is tidal volume is an important determinant as compared to pressure, meaning thereby high pressure without high tidal volume will not cause ventilator induced lung injury. If the high pressure is leading to high tidal volume, then only there would be ventilation induced lung injury due to barotrauma. The next important thing is we have biotrauma. So whenever there is a atelectotrauma or this volutrauma, it causes this basement membrane alteration of the structure, and that in turn leads to activated neutrophil and macrophages, which releases mediators of inflammation like tumor necrosis factor alpha, interleukin 1 beta, interleukin 6, interleukin 8, ultimately causing cascade of inflammation and affecting other organs in addition to lungs. It could be kidneys, intestine, and the patient can mimic as a baby having sepsis. Next, we have rheotrauma. So this rheotrauma can happen due to high flow rate as well as low flow rate. Both of them can lead to low tidal volume delivery, which could be due to excessive turbulence or flow starvation. And then we have oxytrauma. So we are already aware that hyperoxia leads to free radical oxygen generation, and neonates have very poor scavenging systems and antioxidant mechanisms. So this is an important mechanism behind ventilator induced lung injury. So if I move on to consequences, we know that the baby who is on mechanical ventilation, and if there is an excessive tidal volume or atelectasis, then the initial thing that would be happening is volutrauma and atelectotrauma. So they are the main deciding factors that how the lungs or body is going to further behave with this hit by the ventilator. So this volutrauma and atelectotrauma, they would be causing then biotrauma. There would be release of cascade of inflammatory mediators, which would be causing ventilator assisted lung injury or ventilator induced lung injury, we can say. And these inflammatory mediators can cause lung edema due to increased capillary leak and fluid in the interstitium, which would be ultimately leading to non-homogeneous lung aeration. And the inflammatory response, as I discussed in my previous slide, could be pulmonary and systemic. Pulmonary, we know, ventilation induced lung injury, and in systemic, it could be worsening of ductus arteriosus, reopening of PDA, and which ultimately causing worsening compliance and gas exchange and increased ventilator support. So there would be a cascade of all these events and ultimately the vicious cycle. And in addition, there would be multi-organ dysfunction syndrome, which would be accounting to hemodynamic instability as well. So the additional further risk determinants in our extreme preterm babies or fragile neonates are antenatal infections, premature lungs, compliant chest wall, premature antioxidant mechanisms, insufficient nutrition, and postnatal glucocorticoids. All these will further precipitate or act as an add-on modifier to this ventilation-induced lung injury. So how we can prevent this? So, in this whole, lecture series, so many things have been already discussed. So, I would be discussing these three things, like more use of non-invasive ventilation, surfactant administration in and lung protective ventilation in very brief, and mainly I would be covering early weaning and extubation, the role a role to prevent ventilation induced lung injury. So more use of non invasive ventilation is definitely the important strategy that would help us in preventing ventilation induced lung injury. And among the various non-respiratory support strategies, non-invasive positive pressure ventilation has been found to be more effective in decreasing invasive mechanical ventilation than CPAP or HFNC. In addition, it has been found that NIPPV reduces air leak, as well as there is a lesser incidence of BPD or mortality versus CPAP. When it comes to surfactant administration, we know that early surfactant has a great role in improving the respiratory outcomes of these tiny fragile humans. So it decreases the risk of acute pulmonary injury, air leaks, both pneumothorax, pulmonary interstitial emphysema, and ultimately leading to decreased risk of neonatal mortality or chronic lung disease. Among the various methods of surfactant administration, less invasive surfactant administration techniques, LISA, MIST, they have been found to be more useful when compared to ensure technique. Then we have lung protective ventilation. It has been already discussed in detail, but the main point that we need to remember is we have to minimize volume trauma, we have to prevent atelectative trauma, and we have to optimize of FRC by reversing atelectasis. This all these three would actually aim to open lung ventilation strategy, and by this way, the optimal tidal volume throughout the lung will help in improving oxygenation and decreasing FiO2 requirement, thereby ultimately decreasing oxygen toxicity. So next part of my talk is weaning and extubation. So we already have discussed and we know that why it is important to wean. So when one should start wean and how to wean. So while we are weaning, the mm, on pressure support and volume targeted ventilation, there are different things like how one should wean. But the important parameter thing to remember is we should change one parameter at a time, and be it any mode, FiO2 should be weaned first because of the oxytrauma or free radical related injury. So, and it is said that once your FiO2 is has reached to 60%, then you should start decreasing pressures. So, on SIMV, with or without PSV or assist controlled SIPPV, we decrease FiO2 followed by PIP, and in SIMV additional, there is a role of decreasing rate. When it comes to volume targeted ventilation or volume guarantee, as we are delivering a volume, so after weaning FiO2, target a tidal volume, we can wean, but one should avoid less than 4 ml per kg. The setting should be reduced every 4 to 6 hours, and one can reduce FiO2 at 5 to 10% at a time, PIP 2 to 3 centimeter, PEEP 1 centimeter, and rate 5 to 10 per minute. So, what are the minimum ventilator settings when we should consider weaning these babies? So, on a conventional mechanical ventilation mode, it has been said that PIP of around 14 to 16 centimeter of water, PEEP 6, rate 20 to 30, and FiO2 of 30%. Same in the assist control mode. So all these settings would actually correspond to mean airway pressure of around 6 to 8 centimeter of water and FiO2 of 21 to 30%, and additionally a rate of 20 to 30 in SIMV. If these babies on these minimum settings, then we can plan of extubating this baby. And in volume targeted ventilation, we have FiO2 30% and tidal volume if 4 to 5 ml per kg. And high frequency ventilation has already been dealt in detail by Dr. Monica, but still it is like map of 7 to 9 centimeter. One can think of extubating or weaning and FiO2 of 30%, and the baby can be directly weaned off to, the non-invasive mode of respiratory support. So when we are planning for now, our baby is on minimum ventilatory setting. So how one should proceed? So there are certain extubation readiness assessment methods, which have been used by various studies, and these are basically physiological parameters and clinical parameters. Physiological parameters further include pulmonary function tests like tidal volume, minute ventilation, functional residual capacity, compliance, resistance, respiratory muscle strength, maximum inspiratory pressure or tension time index, breathing patterns like respiratory rate, inspiratory and expiratory time, and cardiorespiratory behavior, heart rate variability, and respiratory variability. And then there are clinical parameters, which includes vital signs, oxygen requirement, and apnea. So when it comes to physiological parameters, it has been seen that none of them have been found to be effective. All these parameters, most of them needs complex monitoring techniques, and there is a lack of strong evidence to support their use, and there is no added benefit in identification of extubation failure. Moving on to the most commonly done test in neonatal intensive care unit before extubation, that is spontaneous breathing trial. So, what is done in spontaneous breathing trial is once a baby is on minimum ventilatory settings on mechanical ventilation, the extubation readiness is assessed by putting baby on ET-CPAP for 5 minutes. Most studies have used a duration of 3 to 10 minutes with the CPAP of 5 to 6 centimeter. And then baby, there are certain parameters, physiological parameters like apnea, presence or duration of bradycardia, that is heart rate less than 100 beats per minute, presence or cumulative duration of desaturation, SpO2 less than 85%, and need for supplemental oxygen or maximum amount of oxygen required that time. All these are assessed, and if there is no worsening, then the baby is said to be passing that test and extubated to NIV. But if the baby is not fulfilling all these criteria, then the um, invasive mechanical ventilation is continued. But in a systemic review and meta-analysis by authors Salish, William et al., uh, they did this study, and basically 289 preterm infants were included, and what they found is the spontaneous breathing trial though has high sensitivity, but specificity was very low, and almost more than 50% of the infants who were exposed to this spontaneous breathing trial had clinical instability without improving detection of extubation failures. Moving on to our next parameter, or next, tool that can help us in deciding the readiness for extubation. And this is lung ultrasound and its role in extubation prediction. So, lung ultrasound has, in a recent time, lung ultrasound has shown encouraging performance in detecting extubation readiness. So the lung ultrasound can be used to, the extubation readiness can be assessed based on the lung aeration, presence or absence of lung edema or consolidation, and then the additional parameters like diaphragmatic thickness fraction or excursion can be used to determine the sensitivity and specificity. So as we are all aware, these are the scores are most commonly used. These are the scores that have been used for deciding the need for surfactant in babies with RDS as well. And score 0 means there is a good aeration. Score 1 would be there are 3 or more than 3 well spaced B lines. Score 2 corresponds to coalescent B lines. Score 3, there would be fluid alveologram with subpulmonary consolidation. And then score 4, there would be extensive consolidation. So, in a, systematic review and meta-analysis, it has been found that the various studies of, there were 8 studies, and what authors found that the different studies have included different zones. Most commonly, the anterior and lateral zones have been included, that total 6 zone, and the total maximum score, some of them have included 3 and some of them have 4, like 18 to 24, and one of the study have included 40 also. So what they found is, taking all these parameters into account, the pooled sensitivity and specificity of this lung ultrasound in predicting lung extubation prediction was 82% and 83% respectively. These studies were having less heterogeneity immunogenicity, but it was found that high risk neonates were very less. So it this modality also needs further validation and standardized protocol in high risk babies. So next comes is the role of machine learning and extubation prediction. So being a complex etiology and the mechanism that is behind the extubation failure in especially this fragile babies, so it seems very logical to utilize the role of machine learning and using composite test rather than a single test to predict the success of extubation. So the similar study was done, which is actually a prospective multi-center observational apex, that is automated predictor of extubation readiness study. And what authors did in study that they included clinical parameters and cardiorespiratory behavior of babies who had birth weight less than 1250 gram, and they were being extubated first time to non-invasive respiratory support. So birth weight, gestational age were included in clinical parameters, and then cardiorespiratory parameters include heart rate variability and respiratory rate and respiratory variability. And all these patients, these data were actually recorded for continuous 60 minutes when the baby was on mechanical ventilation, and then after extubation or on ET-CPAP, next 5 minutes, all the parameters were recorded and then they were incorporated into an algorithm method. And with this, what they found is there was a balanced accuracy of these both two parameters of around 73%. And when it was applied to extubation, within, first 7 days, the balanced accuracy was 80%. And it was around 68% in more than or equal to 7 days. So, but the issue with this is we need simplification of equipment and data acquisition systems, and along with the more collaboration with the advanced, scientists and the equipment and the more knowledge to apply this in a practice. So, after covering this extubation, various test use. So, it is like extubation is sometimes it is art, sometimes it is science, and sometimes it may be a gamble in very preterm babies. So once a baby is off sedation and having normal sensorium, there is improvement or resolution of the primary cause for which the baby was intubated. Baby is hemodynamically stable, there is optimal nutrition, no fluid overload. There are improving or normal lab parameters, especially hemoglobin and electrolytes, and blood gas is normal. That is, there is no hypercarbia or hypoxemia. Then one can think of extubating these babies. So, what is the optimal extubation timing? Well, there is still, there is not much data, especially in extreme preterm babies, but it is said that term neonates and children can be extubated as soon as the extubation criteria is fulfilled. And among preterms, there is no robust scientific evidence, but the success of extubation is mostly defined by the gestational age, birth weight, and associated additional risk factors. So, in a survey neonatal physicians done, it was actually found that most of us do prefer to extubate babies within 72 hours. Moving on to peri-extubation care. So I would be covering the medications, respiratory support, and nursing care. So medications during peri-extubation period, they are mainly used to enhance respiratory drive, reduce lung injury and airway inflammation, and avoid bronchospasm. So to enhance respiratory drive, the most commonly medication used in neonatal intensive care unit is caffeine. And well, it has been found to reduce extubation failure by 50%. And there is a strong recommendation to use caffeine in peri-extubation period. Indication is less than 34 weeks and in between 34 to 36 weeks, depending on the clinical judgment. When should we start? 24 hours before elective extubation or within 6 hours of unplanned extubation if the baby was not already on caffeine. Dose is 20 mg per kg loading dose followed by 5 mg per kg. It has been said that high dose of around 40 to 80 mg per kg loading dose and maintenance of 20 mg per kg can be used in case of complicated extubation. But there are some serious concerns with high loading dose in preterm babies, especially in first 3 days of life. It has been found to be associated with cerebellar hemorrhage, so it should be definitely avoided in these babies in first 3 days of life. When it comes to doxapram, there is little to no difference in failed extubation and there is no much evidence. Moving on to medications to reduce airway inflammation and bronchospasm. So, most commonly used medication is adrenaline or epinephrine. So, nebulization is used left and right in neonatal intensive care units. So, for the evidence, there is only short-term outcomes are reported. So the use is basically it can be used for post-extubation stridor at a dose of 0.2 mg per kg. For salbutamol, there is no data available. For dexamethasone, yes, it has been found to reduce extubation failure with number needed to treat 11, but there is uncertain evidence overall because it has been associated with long-term risk of poor neurodevelopment outcome. So indication of dexamethasone is only for some specific set of patients, which could be previous extubation failure due to stridor or prolonged intubation more than 7 days. Dose is 0.25 mg per kg and it should be started 4 hours before the planned extubation and continue 8 hourly interval for next 3 doses. So some special scenarios like term infants and infants undergoing extubation post-surgery, there is limited evidence to decide on the medications used prior in the previous slides. Moving on to respiratory support. So we know that non-invasive respiratory support is definitely better as compared to in improving the extubation readiness, and in non-invasive also synchronized non-invasive positive pressure ventilation has been found to be superior to non-synchronized to nasal HFOB and variable flow CPAP. Synchronized, and it has been seen that BiPAP, variable flow CPAP, and HFNC have comparable rates as per this network meta-analysis uh, reported in the Journal of Pediatric and Child Health. Moving on to nursing care. So, nursing care is really important in reducing the extubation failure and for having extubation successful in these preterm babies and all in fact all high risk babies in neonatal intensive care unit. So properly fixed nasal cannula, and we should ensure minimal leak. There is a role of swaddling and KMC, and the baby has to be assessed for secretions and airway clearance should be done as and when needed. So regarding chest physiotherapy, it has been found to decrease the need for reintubation in first 24 hours post-extubation, but there is no difference in preventing post-extubation lobar collapse by using chest physiotherapy. So when should we define extubation failure? Extubation failure is rate is really very high in extreme low birth weight babies, and there are various different definitions have been used to define extubation failure. But overall, we can see any baby who has increased work of breathing, severe apnea requiring positive pressure ventilation, multiple episodes of apnea that is more than 6 within 6 hours, and then there is a need of FiO2 more than 50%, along with there is a respiratory acidosis and hypoxemia to maintain SpO2 of 91 to 95%, then the baby can be labeled as extubation failure. Some of the studies have reported more than 20 to 30% requirement increase has been labeled as extubation failure. So when one should label, so the window is actually it can be 3 days, 7 days in some studies. So it is found that 7 day window should be especially used in high risk neonates, as the 7 days window it captures 80% of the respiratory and less than 15% of the non-respiratory causes related reintubations. Non-respiratory causes related reintubations are most common sepsis in our scenario, or NEC or some other causes. So when a baby is failing extubation or failing extubation multiple times, we should know the causes, like how we can prevent that. For that, it is important for us to know the scenarios where extubation could be really challenging or difficult for us physicians. So decreased respiratory drive is found to be one of the important determinant for that. It could be seen in extremely premature babies, babies with HI or CNS disorders. And the other set could be neuromuscular disorders like muscular dystrophies, atrophies, brain malformations, neuromuscular blockade, or diaphragmatic palsy or dysfunction. Then there could be airway malformations due to ventilation-induced lung injury or congenital airway or lung parenchyma anomalies, air leak syndrome, multiple extubation already happened leading to airway trauma or chronic ventilation. And last, we have cardiac issues like hemodynamically significant PDA or babies with critical congenital heart disease with increased pulmonary blood flow. So here are some case scenarios where we can see that diaphragmatic palsy should be ruled out in any baby where there is a history of traumatic delivery, abnormal presentation, and there is recurrent extubation failure. Then the recurrent extubation failure could be happen in a spinal cord injury in a neonate, which is most commonly missed, and it is not though a very common scenario also, but one should remember that this is also a cause of recurrent extubation failure in an infant. Then we have airway anomalies, actually malformations, which usually happens due to a baby on prolonged ventilation, and it could be laryngotracheal, esophageal cleft, tracheomalacia, or sometimes congenital tracheal stenosis. All of them can result into the repeated extubation failure. So, what is the targeted approach for extubation failure? So, if we define that our extubation failure is happening within 48 hours or 48 hours to 7 days, or there are multiple failed extubation, we can further plan our management. So, within 48 hours, it mostly happens due to upper airway edema or obstruction or low FRC or immature lungs. So, one should consider peri-extubation steroids in these subset of patients and should extubate to high settings. NIPPV is preferred over CPAP. Next, we have the second group where there be failure in 48 hours to 7 days. And mostly these patients may have increased apnea, bradycardia, which may be due to immature respiratory control or suboptimal NIV, non-invasive respiratory support. So these babies can be given high dose of caffeine on a case-to-case basis. Extubation to NIPPV and upper airway care is an important aspect in these babies. Appropriate size mask, nasal prongs, and frequent suctioning and sometimes prone position may help in these scenarios. And when there are multiple failed extubations, one should actively investigate the baby to look for tracheomalacia, diaphragmatic palsy, or subglottic stenosis. And in these cases, uh, we can have ENT opinion, bronchoscopy, MRI spine, and nerve conduction studies. So, my take home message would be lung protective ventilation and early extubation are key to preventing ventilation induced lung injury. Extubation planning should start since intubation. Spontaneous breathing test and other tests for extubation prediction are not advised. And extubation checklist and evidence based peri extubation support is mandatory to prevent extubation failure. Thank you.